Morning, everybody. I welcome you to the weekly resident lecture series. It's given today by Michael Würdinger. He is resident with us now for the last 3 years, and his topic is focused on technique of pancreatic resection. So we talk today more on the technical aspect rather on indications and diseases.
Thanks for the introduction and also for the help with the preparation of the presentation. I talk about resection techniques in pancreatic surgery today, and I want to focus on the five most important procedures. Then, maybe the most frequent one is the partial pancreatectomy, pancreatic duodenectomy, then the distal pancreatectomy, the Appleby procedure as a special kind of distal pancreatectomy with a celiac trunk resection, and the total pancreatic duodenectomy, and then at least the enucleation of tumors in the pancreas. And for each procedure, I want to show the indications, then the technique, and in the end, the complications that are quite frequent in these operations. So I want to start with a short repetition of the anatomy of the pancreas. It is localized in the retroperitoneal space, and it consists of the head, the body, and the tail of the pancreas. The head is surrounded by the duodenal sea, and the borderline between the head and the distal pancreas is made by the superior mesenteric vein, which is just in the back of the pancreas. And this is important for the procedures later. The pancreas is perfused over the celiac trunk on the one hand and over the superior mesenteric artery on the other hand. The distal pancreas is perfused only over branches of the celiac trunk of the splenic artery, and the head is perfused on the one hand over the gastroduodenal artery and on the other hand over the SMA, with collaterals to the gastroduodenal artery that are the pancreatic duodenal arteries. And the venous drainage is supplied by the splenic vein and by the superior mesenteric vein. So I start with the partial pancreatic duodenectomy. And I want to start with the indication. That would be also my first question to the residents. So can anybody name me maybe 3 typical indications for resection of the head of the pancreas?
So I think the most common indications is a pancreatic adenocarcinoma or a cystic lesion in the pancreatic head.
Yes, that's right. Another one?
Maybe ampullary cancer?
Yes, that's also right. So we have the adenocarcinoma, we have malignant tumors of the pancreas itself. So this is the adenocarcinoma, then malignant neuroendocrine tumors of the pancreas, then the carcinoma of the papilla of Vater. We have precursor lesions, the IPMN, and then we have malignancies of other structures just next to the pancreas. That's duodenal cancer and the distal cholangiocarcinoma. And of course, we can also have a trauma which has to be resected then. The IPMN is it is called intraductal papillary mucinous neoplasm. It is a precursor lesion, or the most important precursor lesion of the adenocarcinoma. And we have the main duct IPMN on the one hand and the branch duct IPMN. And we have also mixed types. And it is important that in main duct IPMN, the malignancy risk is quite high, with up to over 90% of lifetime risk, whereas the branch duct IPMN has a lower risk for malignancy. So the main duct IPMN is an indication for resection, whereas the branch duct IPMN is not. And in mixed type, the main duct IPMN is the leading lesion, and this also has to be resected. Then the pancreatic cancer is divided in resectable lesions, in locally advanced lesions, that means unresectable lesions, and in borderline resectable lesions. And the resectable lesions have no infiltration of any vessels and clear tissue planes. The borderline resectable lesions have infiltration of the veins that can be resected, but no infiltration of the arteries, and also no encasement of the arteries more than 180 degrees. And the locally advanced tumors have also an infiltration of the arteries or an encasement of the arteries of more than 180%. So the treatment would be for resectable lesions a primary resection, for borderline lesions also a primary resection or a resection after neoadjuvant treatment, and for locally advanced tumors which are unresectable, systemic therapy. And if we go for resection, we have for the head of the pancreas, we have on the one hand the classic Couch-Whipple procedure with a resection of the pylorus and on the other hand the pylorus preserving pancreatic duodenectomy, which is the Traverso-Longmire procedure. And both can be done with or without the portal vein resection. I want to explain the technique. It starts with the opening of the lesser sac. It's not shown here. And then we start with the so-called Kocher maneuver. That means a mobilization of the duodenum from the retroperitoneum. Then in the next step, the preparation with a transection of the GDA. Then the transection of the stomach in classic Whipple or in pylorus preserving of the duodenum. The transection of the bile duct and the cholecystectomy before. And in the end, the transection of the pancreas at the border between head and the body of the pancreas. And this is along the SMV. So we start with a tunneling of the SMV, and then along this line, a transection of the pancreas parenchyma. Then the head, the duodenum, and the distal part of the stomach are en bloc removed, and a local lymphadenectomy is performed with at least more than 12 lymph nodes. And on the right hand, we have the anatomy after resection. We see the transection surface of the pancreas. There's a duct here. We have the SMV, the venous confluent, and the portal vein here. That's the transection line, the bile duct, and here is the celiac trunk. Here's the GDA sutured. And after that, we start with the reconstruction. It can be done with a Roux-en-Y reconstruction, or as shown here, with an omega loop reconstruction. There are three anastomoses. The one is the pancreatico-chichonostomy, the other one is the hepatico-chichonostomy here, and then the gastro-chichonostomy. And in case of a pylorus resection, like here, it is recommended to do a brown anastomosis between both limbs of the jejunum to avoid bile reflux into the stomach. And this is also a picture from a patient we operated. We see here the pancreatic surface with the duct and the sutures inside. And then in the end, the pancreatic chichonostomy in 2 rows over here. So the question is, or was for a long time, which one is better, the Couch-Whipple operation or the Traverso-Longmire operation? And this is a study from last year. It is an RCT from Heidelberg. And they showed that there is no difference in outcomes in both procedures, even not in risk for delayed gastric emptying, which was meant before to be lower in pylorus resection. So I come to the complications of the Whipple's procedure. So can anybody name me the most important one?
Yeah, I think it's a pancreatic leak.
Yes, it's a pancreatic fistula. So we have here the rates of the benchmark study of our department. What we can see is that even in benchmark cases, the morbidity rates are quite high, with about 2/3 of patients which have any complication. We have a fistula rate of about 20% in these patients, a bleeding risk of lower than 10%, and also this delayed gastric emptying is quite high with 1/3 of patients. Mortality is quite low nowadays with 1.6% in these cases. On the other hand, we have sequelae, that means expected consequences of the operation, and these are the diabetes. In resection of the head, it is about 10%, and the exocrine pancreatic insufficiency. So now I want to show a patient with a portal vein resection. This is a 76-year-old patient with an adenocarcinoma of the head, which was borderline resectable. That means an infiltration of the veins. As shown here, it is an infiltration of the superior mesenteric vein. And he was operated a few weeks ago in our department with a complete resection of the head en bloc with a complete venous axis. And we see here the remaining parts of the SMV, the splenic vein and the portal vein. And then we made a reconstruction with a venous conduit, like shown here. And this is the end result. And the outcomes with portal vein resection are quite good compared with a standard procedure, as shown here in a few different studies. The morbidity rates are about 40% in both procedures, and the mortality rates as well lower than 5%. So we can say portal vein resection is a good option to increase the local resectability with a minimal increase in morbidity and mortality rates. So I come to the next. It's the distal pancreatectomy. The indications are quite the same like for the resection of the head. So it is a cancer of the pancreas. It's an IPMN. We have neuroendocrine tumors, and we have also chronic pancreatitis with pain and trauma. And the distal pancreatectomy can be done with or without a splenectomy. We have to do it with splenectomy in case of malignant diseases. And in benign diseases, we can do it without a splenectomy according to the technical feasibility. And the pancreas can be resected from the left to the right side or from the right to the left side. This is the technique for, like, we do it mostly in our department from the right to the left side. It starts after opening of the lesser sac with the mobilization of the distal pancreas in the inferior edge of the pancreas. Then we do a tunneling again along the SMV, as shown here. Here's the SMV again. Here's the pancreas over there. And we do a tunneling again, then the transection, and then the en bloc mobilization of the distal pancreas here with both splenic artery and vein, which are ligated. Then the mobilization of the spleen, and then the en bloc resection. This is the anatomy without the preparate, and this is the preparate. In this case, from a patient with an adenocarcinoma of the distal pancreas. Maybe over here. The complications are quite the same like in the partial pancreatic duodenectomy. Mortality rates are also low with 2%. The morbidity is also high with over 50%. And which is important is that the pancreatic fistula rate is really high in these patients. It's about 50% of patients that have a pancreatic fistula. We have the sequelae also of the diabetes, which is higher in these patients because the islets are more in the distal part of the pancreas. And we have, in case of splenic resection, also a risk of the so-called overwhelming post-splenectomy infection. That means fulminant sepsis due to infection with capsulated bacteria. On the right hand, we see a patient with these problems and a DIC with bleeding. And the lifetime risk for this infection is about 5% for these patients. Now to the next operation, we have here a patient with an adenocarcinoma of the body of the pancreas with infiltration of the celiac trunk. And as said before, actually an arterial infiltration is actually a non-resectable tumor, but there is an operation which allows a resection of this tumor. And this is the Appleby operation with resection of the celiac trunk. So it is a two-step procedure. It starts with an embolization of the common hepatic artery over here in the first step before the actual operation, so that the perfusion of the liver is not over the celiac trunk, but over the SMV with the collaterals in the head of the pancreas and the GDA over here. Here's a scheme again, and we see that these arteries in the head of the pancreas supply the blood flow to the liver. And then in a second step, the resection of the distal pancreas with the tumor and the celiac trunk can be performed. Here's the anatomy after the resection. We see the transection line again of the pancreas. This is the head of the pancreas. Here the venous axis. And here the aorta with the resected celiac trunk. And the outcomes of this operation are quite good for arterial resection. We have pancreatic fistula rates of about 20%. Bleeding is the same as in the other procedures. But what we have to say is that the risk of liver ischemia is quite high, with about 17%, with the consequence of a high mortality in these patients, with 60% of patients. And the sequelae are the same like in the distal pancreatectomy, with diabetes and risk of infection. Additionally to that, we have the risk of chronic diarrhea due to the denervation of the vagal nerves next to the aorta. And the oncological outcomes are quite good. It's the median survival rate is with 18 months in these patients, almost the same like in the other procedures. Then I come to the total pancreatic duodenectomy. The indications there are also extended main duct, IPMNs, multifocal pancreatic cancer, chronic pancreatitis with persisting pain in patients, traumas, or a completion of the pancreaticectomy for rescue in a higher grade fistula. Here's the technique again. It starts like the distal pancreatectomy with mobilization from the left side, with the mobilization of the spleen and the distal pancreas. Then the transection of the stomach, of the splenic vein and artery, then the mobilization of the head with the transection of the GDA over here and the bile duct. This is again the anatomy without after resection. We see here the splenic artery, which is cut, the splenic vein, the SMV, portal vein, the bile duct. This is the GDA, and here's the celiac trunk. And this is the resected. It's the, you can see here the duodenal C, the head, and the distal part of the pancreas is the spleen. In this case, of a patient with chronic pancreatitis. And then after that, the reconstruction is done like in Whipple's procedure, but of course without any pancreatic jejunostomy. So I come to the complications again. So my last question is, what is the advantage of this procedure compared with the others?
No pancreatic fistula.
Yes, exactly. So we have no pancreas anymore, so we have also no pancreatic fistula. And the consequence of this is that the morbidity is a little bit lower in these patients, and the mortality rate is also low, but with the cost of 100% rate of diabetes and exocrine pancreatic insufficiency, of course. So come to the last point, the enucleation. The only indication for this procedure is because it is not an oncological resection. It is a benign pancreatic neuroendocrine tumor. It has to be small, lower than 2 centimeters, and non-functioning, or if it's functioning, it's in insulinomas or gastrinomas, because the others have a high rate of malignancy. Here we can see the status of a patient with an insulinoma of the distal pancreas. Procedure starts with the tunneling again here for control of the vessels in case of bleeding, and then luxation of the pancreas, and then resection of this tumor. Here's the resected. And it is a tissue-sparing procedure, so it has the advantage that the sequelae are quite low. We have low rates of diabetes and exocrine pancreatic insufficiency, but the morbidity is also high, with 2/3 again, and the pancreatic fistula rates in these patients are quite high, with over 50%. So that's the different procedures. I want to show 2 slides about current developments in pancreatic surgery. The minimally invasive pancreatic resection is more and more established, especially in enucleation and distal pancreatectomy. We have the laparoscopic on the one hand and the robotic procedure on the other hand. And I just want to say that there is only few data about the outcomes in these procedures. I haven't found any randomized controlled trial, but there are observational studies, for example, these 3, and they show that it seems that they have the same oncological outcomes like the open procedures, with a shorter length of hospital stay and a shorter time to normal oral intake. So this is the advantage of that procedures. So to come to the end of my presentation, I want to give a quick overview about the mortality and morbidity of the different procedures. We have the bleeding with lower than 10%, about 5 to 9% in all operations. Then the most important complication is the fistula. It is quite high in distal pancreatectomy and in enucleation with over 50%. The morbidity is in all procedures high, with about 2/3, with the exception of the total pancreatectomy, which has the mentioned sequelae. And the mortality rates are rather low nowadays, with the exception of the Appleby procedure, with over 10% due to liver ischemia. So, yeah, I come to the end of the presentation. Are there any questions?
Well, thank you very much for this presentation. I mean, in 20 minutes, it's not easy to cover all the operation. I think it was a good overview and very well presented for those with no idea about pancreas. I think they know a little bit more, I hope, at the end of your talk. Just one operation you did not mention is the central pancreatectomy, which we don't do very often here. There's not so much data. So this will be also a very selective operation. So I think it's a good idea maybe not to cover this one. You mentioned here this benchmark study that was done with 23 centers worldwide here. In fact, as a premiere was just accepted yesterday, so it will be published in the Annals of Surgery here. And we compare in that study a little bit the laparoscopic and the robotic procedures. And I think it nicely shows also we have no data today. And most likely the outcome, particularly outside of expert center, is not as good as the open procedure so far. So we have to be very careful with the robotic versus the open procedure. The single most important factor, I still believe, in outcome is experience of the center, is experience of the surgeon, not only the surgeon, but ICU, etc. If patients are mismanaged during surgery with tons of liters, you can have the best team around the table, the best patient for surgery, the outcome will be poor. So here there is also a very important role of other people for the success of this operation. So centralization or operation done in Switzerland has been not a very good example in this field, whether it's pancreas or others, since we had, I think, more than 70 hospitals doing this procedure in the past. Now we still have, I think, in the 40s or more. And there is really here, we need data and convincing evidence that this procedure can be centralized and done in center when they can offer all what's necessary for the success. I have one question, what I was looking here, which I did not expect this value, which was diabetes after, for example, distal pancreatectomy or even Whipple. I think you mentioned 10% after Whipple and 30% after distal pancreatectomy. That seems extremely high. Were this patient diabetic preoperatively, which of course the pancreatectomy would not help them, or is that really a sequela or a complication of the procedure. That seems to be very high in patients. If they have chronic pancreatitis, that's probably, but in patients who have IPMN or something like that, we do the distal pancreatectomy. I don't remember patient who developed diabetes. Maybe I'm wrong, but I think that figure is quite high. So I don't know if you have more data about this diabetes. It's just out one paper.
Yes, it's just one paper, and they didn't mention anything about the preoperative diabetes rate.
So I would be very cautious with this figure. That seems very, very high. Is for us, I mean, and that's important for the informed consent for the patient, because when I go for a Whipple patient, I basically tell them there will be no diabetes after, unless of course there is a risk for this. So problem before, but they don't have diabetes and distal also. No, total pancreatectomy, of course, it's the complete pancreas resection from this procedure. So I don't know if there's any question or comment.
I have two questions. The first relates to the rather high rate of pancreatic fistula after distal resection, and I can remember when I started 20 years ago, I was told it's absolutely mandatory to do a fish mouth shaped excision of the border and oversew it and oversew the duct. Then there came a period with staplers, and now we have seam guards, but it's still 50%. Is there any solution? Is there any progress that has been done in this high rate of fistula? Is the first question. And the second question relates to the Appleby operation. You resect the trunk, you close the left gastric, you close the splenic artery, and just a technical idea, how do you make sure that you don't have problem with perfusion of the stomach and the distal pancreas and the spleen? How do you make sure that this doesn't become necrotic and we have a major problem? It's just I think a technical thing.
The first question is like also many technical aspects, whether you do an anastomosis of the stump of the pancreas in Whipple with the stomach or the jejunum. There's many papers. Some centers have claimed that they never seen any fistula when they plug the pancreas to the stomach. There is no really serious evidence of this. I think it's good to know different technique because there are different situations where there is an advantage for that. As far as your question, the distal pancreatectomy, now we have nice stapler. Maybe it's better, I don't know data, but all the studies that have really been done have not shown much differences with stapler. I think this is right now. I think there is no one that can claim there is only one single technique here. We use this coated stapler, and it's also to do with the pancreas. Is a thick pancreas, hard pancreas, but this fistula rate after distal pancreatectomy is clearly a problem, but it can be drained. It's less serious, I would say, that after Whipple, some of those complications, but they can sometimes last a long time in some of these patients. There is no specific technique. As far as the Appleby, you show very poor outcome. Results that are quite worrisome, 10% mortality. I think no one in the world has a very large experience with Appleby operation. This is a specific indication, but here I think that has really to do with the indication and be very careful. I think you need absolutely to document that the flow is absolutely good to the gastroduodenal artery, go back to the liver. Here, the few we have done here, we had good outcome from the surgery to this. I think it's a very good operation, but it absolutely has to be done and I agree with you, I'm more worried about ischemia of the stomach than ischemia of the liver, because I think that if you're very careful or don't do the operation, if the flow is not optimal, then I think you should, I would speculate that the risk of liver failure is lower than 10%. But the stomach, here depend of the tumor, you can devascularize here, and you did not report, but there's certainly a number of cases where you end up to do a total gastrectomy after, which of course add a lot to the morbidity. So I'm more worried in this when we do it as for the stomach. But the figure of ischemia or the stomach is quite tolerant to ischemia, it can recover, but I don't know any figure about this.
I think you have to be careful that you don't injure the right gastric artery. So, because if you dig too much, if you transect too much, it might be you will dissect the right gastric, which can be preserved, and then might be you're in trouble. This is my recommendation, that you have to be careful, because it's very easy to cut this vessel. Sometimes it's small, so you should really, really preserve the right gastric. And it's very easy just to cut and ligate, and then you have a preserved inflow sacrificed. And the other things I agree. Fistula rate in distal pancreatectomy, I feel 50%, regardless with stapler and forced stapler, different techniques. It's still high, and therefore I think it's mandatory, and we also train all these patients with distal pancreatectomies. And for the enucleation, it's also, they have a high rate of fistulas, and therefore we also should train these patients afterwards. That's my comment. Okay.
Maybe two points that were a major factor in the risk of fistula and problem is the consistency of the parenchyma. That is very well documented. Soft pancreas versus hard pancreas, small pancreatic very high play a major role, and in fact we use here a different technique. If this is a soft pancreas of a hard pancreas, the hard pancreas don't need to be drained. Usually the fistula rate is 6% or less, and not very serious. While in soft pancreas there is always a higher risk, and here also you mentioned that in some situation where there's a serious fistula, one of the life-saving procedure is not to wait too long, go and take the rest, do a total pancreatectomy, and you can save a few lives when you do that in some of these circumstances. The next point, I believe if for pancreas, the robotic surgery will gain a lot of acceptance, particularly for distal pancreatectomy. The Whipple is still in the hand of a few people who seems to do it successfully, but the distal pancreatectomy, just by common sense, the visualization where we go, I mean, it's established laparoscopically, but I think it will become a standard procedure for the robotic, whether or not you keep the spleen in this situation.
Why is the fistula rate that much better in the Appleby procedure compared to distal pancreatectomy?
I think it's not completely correct to say that the fistula rate is 20% because they refer to only grade B and C fistulas, and the other rates are for also biochemically leaks, so grade A. And I think this is the reason for that number. So maybe it's also 50% when we add the biochemical leaks.
Very nice presentation. I have a question concerning the classification of resectable, locally advanced and non-resectable. Is this a surgical classification or a more oncological classification? Because at the end, technically, as you see in the Appleby procedure, you can do pretty much everything. And is this a classification which predicts outcome oncologically, or just technically if we can do it? And a short question to your survival after Appleby procedure. You said a median survival of 18 months, which is much lower, which we have in the usual pancreatectomy or Whipple procedures. There are even groups which suggest 50 months with FOLFIRINOX postoperatively, and you said it's pretty much the same. So I think your data suggests that it's worse than a normal pancreatectomy, the outcome.
Yeah, I think to the second one, I think the outcome is worse. I've read about 22 months in Whipple's procedure, for example. I don't know.
There are data now that you have 50 with FOLFIRINOX, you have 50 months median survival, which is much higher than
that's true.
What you are suggesting here.
Yeah. And I think this classification about the resectability is due to surgical outcome, actually. Because with artery resection, just exceptional, the celiac trunk resection is we have a bad outcome of after the operation. So not...
Perhaps one comment. So this classification is based on anatomic structures, and important is for the resident, for the youngs, it's on vascular structures, portal vein and SMA and hepatic artery. As you can see on the left side, if no vascular structure is involved, resection is possible without replacement. And then you have in between the borderline and the locally advanced, it's right, you can do everything, but for the mesenteric artery, if you replace it, you have to be careful because the entire small bowel package is dependent on this arterial inflow. So if you get a trouble there, has a high risk for lethal outcome. So some do arterial replacements, we don't do it because we know it's associated with high risk. And also this is also linked now to oncology because as you can see, you had one slide where we had different strategies to approach these lesions. Perhaps you show resection, in one case neoadjuvant treatment with resection and systemic chemotherapy. But we know the new data from FOLFIRINOX, as you mentioned, they are so good that I even would speculate that the resectable lesions in 10 years or 5 years, they will get all FOLFIRINOX if they will tolerate this regimen. The last ASCO data showed also survival benefit for resectable lesions.
Okay, well,
Okay.
thank you very much.